right, guys, I'm sorry this is so late. I have to re-record this for some reason. The other video, it was like it got rewritten over or something like that. I'm not sure. So here's your urinary system disorders. So the importance of the urinary system, the biggest thing is that it removes metabolic waste. So the waste that our body creates, our cells, we gets dumped into our blood puts it into our urine, and then our urinary system excretes it. It also will remove hormones from the body, also drugs. It's a huge regulator in our water, electrolyte, and acid-base balance. Uh, Secretes erythropoietin, and remember that is what stimulates red blood cell synthesis, activates vitamin D, and then regulates blood pressure through the RAS system. So just kind of a general flow of our urinary system. We've got our kidneys right here. Then we have this tube connects our kidney to our bladder called the ureter. And yeah, and then we have the bladder, and then finally we have the urethra. So here's the anatomy of the kidney. I'll let you kind of review this, but I think we're going to be going more towards the pathology here. So the functional unit of our kidney is called the nephron. That's this right here. And so if you see me draw it, I always draw it like this. But each kidney has over 1 million of these nephrons. And so the nephrons are made up. We have the renal corpuscle. So we have the glomerulus. That's this guy right here. And we have Bowman's capsule, and that's going to be this area right here. It's that tiny area inside of the glomerulus. And then we have our renal tubule. So we have our proximal convoluted tubule. That's this one right here. We have our loop of Henle. We have our distal convoluted tubule, and then our collecting duct. And so how do we form urine? So first off, we have the filtration that happens in the renal corpuscles. So that's the glomerulus and the Bowman's capsule. So what happens is that we have this large volume of fluid that's going from the glomerular capillaries. So these capillaries right here, we have fluid going from here straight across through the glomerulus and into our proximal convoluted tubule. Yeah, so into the glomerular capillaries, into the Bowman's capsule, and then finally through the glomerulus. And so we have waste, nutrients, electrolytes, and other dissolved substances. That's what's going to be in this large volume of fluid. But it's important to note that cells and proteins remain in the blood, or at least they should remain in the blood. And so if you start to see cells or protein in urine, then you know that there's a problem. Then we have reabsorption. So whenever we have nutrients that we can reuse, like, so for example, water, electrolytes will actually reabsorb these nutrients via these peritubular capillaries. So we have capillaries right here, right here, and all of those can be used to reabsorb these nutrients back into the blood. And so for this reabsorption, the transport mechanisms that that we can use are active transport. So remember, active transport just requires energy. Co-transport. So typically this will be like we have a few sodium glucose transporters. And so by using the energy that we get to bring sodium past its concentration gradient, we can use that energy indirectly to bring glucose in, or osmosis is just diffusion with water. So the PCT, this area right here, this is where we have most of our water reabsorption, but we also have glucose reabsorption here. Nutrients and electrolytes are absorbed here, and then sometimes amino acids are also absorbed here. And so all of these things we are reabsorbing to maintain homeostasis. So this is just pretty much everything that I was telling you before, how we form urine. So we have blood that comes in from the afferent arteriole. Nutrients get absorbed here into the glomerulus, and then we have the blood with the cells and proteins that returns back to the heart. And then what happens is we have this urine, so we have water, glucose, amino acids, electrolytes absorbed in the proximal convoluted tubule. And then we go down into the loop of Henle, cross to the DCT, and then finally to the collecting duct. And so the hormones that are involved in reabsorption, we've talked about most of these. So ADH, antidiuretic hormone, or another name is vasopressin from the posterior pituitary. So the posterior pituitary's got antidiuretic hormone and oxytocin. And so what happens is that we will secrete this ADH, and it causes reabsorption of water in the distal convoluted tubules and the collecting ducts. And it does this because when we have ADH, we put these little proteins right here in the collecting duct, and these are called aquaporins. And what they do is they just allow water to freely flow. And then whenever the water gets out here, it can be reabsorbed right back into our peritubular capillaries right here, and then this goes back to the heart, back to the body. Then we've got aldosterone, so that's going to be secreted by the adrenal cortex. So got our kidney, and then the adrenal is a little party hat. And so the biggest thing for aldosterone is that it is heavily involved in sodium reabsorption. And remember that anytime we have sodium moving, almost always we're going to have water moving with it as well. And then in exchange for this reabsorption of basically salt water, we exchange it for potassium or hydrogen. Then we have atrial natriuretic hormone, and this is a hormone that's released from the heart whenever we have very, very high blood volume. So basically, atrial natriuretic hormone is saying, our heart is saying we're being stretched from all this blood, and we need to get rid of some of it. And so what this will do is whenever we have the release of this will reduce the sodium in our body and reduce fluid reabsorption, so we can drain off some of that blood volume. And so as we're looking at blood flow through the kidney, we start in our renal artery right here, and then we slowly make our way into our interlobar arteries. So we start here, and then we find our way to our interlobar arteries, which are right here. Then from our interlobar, we go to our arcuate arteries, which are right here, kind of at the very top. Then our interlobular arteries, so those are going to be these little guys right here. Then our afferent arteriole, that's where we hit our glomerulus. So right here is where we start forming filtrate in our nephron. But then that blood will go to the efferent arteriole, to the peritubular capillaries, and then we kind of go in reverse. So interlobular vein, arcuate vein, interlobar vein, renal vein. So if you can just remember pretty much here to here, then that means that whenever you're going back, you just literally have to flip it. And so the glomerular filtration rate, this is really just a measure of how well your kidneys are working, how well your nephrons are working, and how well you're forming this filtrate in the glomerulus. So we have the afferent and the efferent arterioles of the glomerulus. So afferent is going to be blood coming in to be filtered. Efferent is going to be blood leaving. And this is blood that's already been filtered. So the afferent arteriole, again, incoming blood, efferent, outgoing blood. And so whenever we have autoregulation and hormones that control this, what they do is they actually control the glomerular capillary pressure. So they control the pressure in this area. And so whenever we do that, we can kind of change the filtration rate. So if we vasoconstrict the afferent arteriole, so say we make this one go, now it's only this wide instead of how wide it is in that picture, this will decrease the glomerular pressure, because if we have less blood that's able to flow through here, that means we're going to have less blood on this side. So that's going to decrease the pressure. And so because we're decreasing the pressure and we have less blood down here, we're going to have less filtrate that gets formed. We can also have dilation of the afferent arteriole. So like instead of doing vasoconstriction, say we do the opposite, and now we make it this big. So now we have more blood coming in. So that'll do the opposite. More blood coming in leads to more blood over here, which leads to increased pressure and increased filtrate. Or we can vasoconstrict the efferent arteriole. And so what would happen there is that because we have less blood flowing through here, we would have more that's staying in the glomerulus, because if we made this area smaller, it's not going to be able to flow out as easy. And so that will increase the pressure here, which will increase the amount of filtrate. So this is the main ways that we can control our GFR. And so this is basically what I just said, but just in a picture form. So we have the autoregulation. That's what we were just talking about. Whenever we can vasoconstrict or vasodilate the afferent and efferent arterioles, so altering the blood flow to the kidney. Or we can use our sympathetic nervous system, and so that increases vasoconstriction in both of the arterioles. Or we have renin. And so whenever our juxtaglomerular cells, when they sense that we have decreased blood flow to the afferent arteriole, they will activate the RAS system by causing the secretion of renin. And renin is how we kick the RAS system off. So this is the composition of blood and the urine. If you want to read it, I don't think there's anything too crazy here. Just notice that in the filtrate in the urine, there should be ideally zero trace of any proteins. So getting into some of the pathologies, incontinence is where we have loss of voluntary control of the bladder. So they might look down and then realize that they might have accidentally peed their pants. And again, they have no control over this. There's also enuresis, which is the involuntary urination by a child older than 4 years old. So by that time, they should know that they really shouldn't be peeing themselves. And so if they do, and it's involuntary, it's called enuresis. And so this is usually there's some kind of developmental delay, maybe there's a sleep pattern that's kind of messed up, or a psychosocial aspect. So sometimes abuse will result in enuresis. Or stress incontinence, that's more common in women. And what this is that you have urine that goes through, that gets kind of forced through the sphincter because you have increased intra-abdominal pressure. And so sometimes, like coughing, lifting, or laughing, a big one is multiple pregnancies. So they'll maybe they've had 3 or 4 kids, and then they laugh really hard, and so you'll just have a little bit of urine that goes through the sphincter when they laugh really hard. And then overflow incontinence. So that's where we have this sphincter right here, where we have increased intra-abdominal pressure that forces urine through the sphincter. That same sphincter can be faulty, and so when that happens, we have overflow incontinence. And so in older adults, we have the detrusor muscle, and so that may actually prevent complete emptying of the bladder. And so if that's the case, the frequency that they pee will be more because they're not emptying their bladder fully, and also incontinence. And another one is spinal cord injuries or brain damage. So spinal cord injuries, this is why if you get into a car accident, sometimes people will involuntarily pee themselves, and usually that results in some kind of a payout, because it's not good to involuntarily pee yourself, especially after an injury. So you can have a neurogenic bladder. So that's where some kind of nerve damage leads to a spastic or kind of flaccid bladder. And so interference with the central nervous system controls and the autonomic nervous system voluntary controls of the bladder from the spinal cord injury or brain damage can lead to somebody urinating themselves. Or we can have retention, and so this is where you can't empty the bladder all the way. We talked about this a little bit before because it can lead to overflow incontinence. And so a spinal cord injury at the sacral level blocks the micturition reflex. So say you get in a car accident and you hurt your lower back, you could be blocking your micturition reflex. Or another thing that could happen is that you can, after or following general or spinal anesthesia, you might not be able to pee very well. So this is usually why they keep you in post-op until you at least go. All right, so now we're going to look at some of the diagnostic tests. So the biggest one for the urinary system is going to be the urinalysis. So just looking at what the urine actually looks like, because the appearance of urine can actually tell you a lot about your overall health. So if it's straw colored with a relatively mild odor, this is pretty normal. So I always say you're aiming for approximately the color of watered down lemonade. That's the color that your urine should be. Specific gravity of 1.010 to 1.050. And so if we have cloudy urine, this usually indicates large amounts of either protein, blood, bacteria, or pus. If it's a darker color, you need to watch out for hematuria. So there might be some blood in the urine, but also excessive bilirubin, or it could just be highly concentrated urine. So sometimes very early in the morning, because usually you've gone, 7 to 10 hours without urinating. When you first go in the morning, it'll be extremely concentrated. And then if there's just like an unpleasant or unusual odor, it can be dietary. So asparagus is a big one, but it can also be things from like medications or maybe an infection. So I put this picture here just so you could see all of these are urine. So this one, I would be worried about maybe protein or some kind of an infection. Obviously, blood in this one. This one is like overly hydrated, so that's not good. You don't want it like this. This is probably a little bit darker than what you want. So this is more an example of just the dark color that's more concentrated. But some mix in between these two. That's kind of where you want to be. And so for a urinary infection, because we have an infection, we'll have heavy purulence. And then you can also sometimes see the actual gram-negative or gram-positive organisms. So here's the gram-positive ones, purple, gram-negative ones, pink. So whenever urine starts to look wrong or very abnormal, some things we might see is blood. So hematuria, heme is blood, and then urea is urine. So, if it's small amounts, that could be from an infection, inflammation. You might have a tumor that's pressing slightly on a blood vessel, and then it'll kind of leak blood out. Or in larger amounts, so that can lead to increased glomerular permeability. So more stuff is being allowed to go through that glomerulus, and that's not necessarily good. Or hemorrhage. Elevated protein level, so that's called proteinuria or albuminuria. And so remember, you have the leakage of albumin. So albumin is the protein that deals with the pressure in your blood vessels. Or you can have mixed plasma proteins that'll end up in the filtrate as well. And then we have bacteriuria, is where you have bacteria or some kind of infection in the urinary tract. Urinary casts, these will indicate inflammation of kidney tubules. So what actually happens is that we have our area right here. And so a urinary cast is basically where you have a little, I think I actually have a picture. Yeah, actually I do. What happens is you have these little casts that form like this, these little cells that come and they come like this, and then they slough off. But what happens is you have like a cast that forms like this, and it's in the exact shape of the renal tubule because that's where it formed. So here we go. Here's a picture right here. So you can see how all the cells kind of form this cast that are going to be in the shape of a tubule because that's where they formed. Specific gravity is going to indicate how well your tubules are actually working, so how well they're filtering or concentrating urine. So if it's a low specific gravity, you're going to have more dilute urine. So might expect this with normal hydration. But if you have a high specific gravity, this is concentrated urine. So again, with normal hydration, but it is related to renal failure. So if it's beyond the normal hydration, your kidneys are not doing too good. And then glucose and ketones. So when diabetes mellitus or type 2 diabetes mellitus is not well controlled, um, the glucose and ketones in your blood start to exceed the amount that your body can handle, and so it'll start to leak into your filtrate or your urine. So whenever we are looking at blood tests for the urinary system, elevated serum urea and serum creatinine levels are not good. And so basically what happens is that whenever you have a buildup of these urea and creatinine levels, that means that you are failing to excrete nitrogen waste. So if you break down proteins and those proteins get broken down into eventually urea, what happens is that if your body can't excrete it, but you're eating protein, but you have no way to excrete it, you start to have that buildup of urea. And so that's caused by a decreased glomerular filtration rate. Another thing you can see in blood tests is metabolic acidosis. And so this actually indicates a decreased glomerular infiltration rate. So your glomerulus is not filtering as well as it should. This also indicates a failure of the tubes to control your acid-base balance because your tubules should really be controlling this. And then finally, anemia. So in the absence of other problems, this will indicate decreased erythropoietin, and you'll see me write this as EPO, or bone marrow depression. So remember, our blood comes from our bone marrow. So if we have bone marrow depression, that will lead to less blood being made, which will give us anemia. And then obviously decreased EPO. So EPO causes red blood cell synthesis. So if we have decreased EPO, that's going to lead us to anemia. And then electrolytes kind of depends on the related fluid balance. So unless you're really looking at it, it's hard to really compare anything. Antibody levels. So this is big, especially anti-streptolysin O or anti-streptokinase titers. And so we use this to diagnose post-streptococcal glomerulonephritis. We'll talk about that in a little bit. And then elevated renin levels, you can see that. And so if you have elevated renin levels, this would indicate the kidney as the cause of hypertension. Because remember, we have renin. Oops, I always draw this wrong. So we have renin. And it converts angiotensinogen to Ang1, angiotensin 1. And then ACE, angiotensin converting enzyme, converts it to angiotensin 2. And remember, angiotensin 2 is a very potent vasoconstrictor. And so that's why we have hypertension. And then just some other tests we can do. So if we're culturing and some culture and sensitivity studies on the specimen. So main reasons because we want to identify what exactly we're dealing with and then helps to select the appropriate drug treatment. Just a little heads up, FYI, reminder that if this ever happens, make sure that they get samples before you give antibiotics, because if not, it's going to skew your results and you're not going to be able to treat the patient as well. Then we have radiological tests. So this could be radionuclide imaging, angiography if you're looking at the blood vessels, ultrasound, CT, MRI, IV pylography. And what this does is you can actually see the structures of the kidney, any abnormalities that might be causing flow patterns, and you can also observe filtration rates as well. Then we can just do basic clearance tests. So what they do is they do creatinine. They use creatinine or inulin, and they measure how much of it is either filtered or stays in the blood. And this can help you to identify your GFR. Then we have cytoscopy. So this allows you to see the lower urinary tract. You can also do biopsy or remove kidney stones this way. And then obviously a biopsy is whenever you want to look at the kidneys directly, the tissues. So some people, I'm sure everybody knows somebody that's on some kind of a diuretic drug. And so the reason that people get put on diuretic drugs is because we need to drain them of their sodium ions, and then that will allow them to drain water as well. So we need increased excretion of water from the kidneys because we want to reduce the amount of fluid volume that we have in the tissues and the blood. And so this can be a problem in things like renal disease. You don't want to put too much strain on your kidneys. Hypertension, high blood pressure, edema, CHF, liver disease, pulmonary edema. We can use diuretics to kind of drain the body and get some of that water off. Diuretics, so they work a bunch of different mechanisms, just depending on the type of drug that we are using, but all of them increase urine volume. But the only thing you have to worry about is that some of the diuretic drugs are potassium wasting, some are potassium sparing, and this is important because anytime you're dealing with potassium, remember that if this starts to get either too high or too low, you have to worry about dysrhythmias. So you want to be really careful when you're using diuretic drugs. So here's just some of the examples. Hydrochlorothiazide, that's a mouthful. Hydrochlorothiazide, furosemide, a lot of people just know that one as Lasix, spironolactone, mannitol. So when we're dealing with dialysis, so dialysis is where we are artificially doing what the kidney is supposed to do. We're artificially removing waste and draining off some of that excess fluid. And so the goal of dialysis is to maintain homeostasis in the absence of our kidneys or when our kidneys are failing. So like I said, filtration and absorption, there's two different forms. There's hemodialysis and peritoneal dialysis. But what dialysis is doing is it's maintaining homeostasis when our kidneys are failing. So it basically does the job of our kidneys. So dialysis is used to treat patients with acute kidney failure until we can reverse the problems, or people who are in end-stage renal failure who they need a kidney transplant, and this just kind of buys them time until they can get there. So in hemodialysis, we are actually taking somebody's blood out of their circulation, putting it through a dialyzer like this, and then using like diffusion, so it allows transport across the semi-permeable membrane here. Again, from high to low concentration, as always, and that'll remove things like urea, creatinine, maybe any excess electrolytes that you might have. It also uses osmosis, so shifting water across the membrane. And this is also driven by the concentration gradients, but it helps control the fluid overload that might be happening if you have kidney failure. And then we also have ultrafiltration. And so this is the pressure that's going to be actually pulling that water across the membrane to remove the excess fluid, because we're trying to prevent things like edema, high blood pressure, things like that. And so if we're doing hemodialysis, like I said, you put the blood gets pumped into this dialyzer right here. And then as soon as that happens, it gets cleansed, and then that blood gets returned right back to the body. And so the only, I guess, downside for hemodialysis is that you have to have vascular access. So you might have like a fistula, graft, catheter. And so, yeah, so this is done in a hospital or dialysis center. Sometimes they can come to your house if they have the equipment and the training for it. And yeah, so this basically just explains everything that I just said. So usually going to be 3 to 4 times a week, so it's quite a bit, and 3 to 4 hours. So it's not, I mean, it's a pretty long process. And then obviously the complications, just like everything, you have to worry about infection, blood clots. Blood vessels can be damaged, especially if they're, if you're getting this 3-4 times a week for 3 to 4 hours, they can get damaged or sclerose. And you just have an increased risk of infection with Hep B and C, or if like HIV, if the precautions aren't being followed how they should, and you're dealing with blood, then you always have to worry about that. And then peritoneal dialysis. So the peritoneum we use as the natural semi-permeable membrane. So right here we have a membrane built into the dialyzer, but in peritoneal dialysis we use the peritoneum as the membrane, semi-permeable membrane. And so what happens is that we put this diastolate and it drains down here. And so what happens is that the waste will diffuse off from our peritoneum, and then that waste gets drained. So typically it's going to be done on an outpatient basis and at night because during sleep is just the most convenient, not moving around much. And so, yeah, so the catheter gets put with an entry and exit point into the peritoneal cavity. We put down this fluid, and then the fluid drains from the cavity into this container right here. So hemodialysis is going to be more for rapid shifts, but you risk like hypotension, maybe cramps. Peritoneal dialysis takes quite a bit more time, so it is slower. It is home based, so that's good, but you risk something like peritonitis, which is an infection in the peritoneum. And then with both types of dialysis, you do have to monitor fluid status, of course, but you have to also watch electrolytes, and then there's always a risk of infection. So usually some prophylactic antibiotics can be given to kind of prevent some of this infection. And then you also have to worry about what drugs they're on, because sometimes if you're on dialysis, that can cause them to lead up to build up to a toxic level. All right. So now we're going to kind of jump into the disorders of the urinary system. So UTIs, thinking cystitis, urethritis, and pyelonephritis, and then inflammatory disorders. So glomerulonephritis and nephrotic syndrome. So UTIs are incredibly common, and that's because urine is an excellent growth medium. So we have sometimes we have sugar. Ideally, we shouldn't, but sometimes we have sugar in the urine, but we have a bunch of electrolytes. I mean, everything kind of bacteria would need, and then in the urinary tract itself, it's dark and moist. So excellent growth medium for bacteria. And so the lower urinary tract infections, we're thinking like cystitis or urethritis. So cystitis, this is just a bladder infection. And then obviously urethritis is where we have inflammation of the urethra. And then for our upper urinary tract infections, we have pyelonephritis. So basically, pyelonephritis is a kidney infection. Um, so usually it'll have like an ascending UTI basically. So it'll be the renal, pelvis, and the medulla. So we have our kidneys here. We have our renal pelvis, and then we have our renal pyramids. This. And so for UTIs, the most common organism is definitely E. coli by far. And so there are some other species associated with UTIs. This is not micro, so I don't think you have to necessarily worry about this too much. But I definitely would know that E. coli is the most most. My goodness, let me restart that. E. coli is the most common causative organism for UTIs. And I wanted to show you this. So it's definitely more common in women because of, and I put this here because the urethra is actually a lot shorter in women than it is in men. And also the urethra is a lot closer to the anus in women. So I have a picture right here. This is the length in women versus men. It's this entire area. I won't even say that. Let's look just this area right here. So it's probably almost double to triple the size. So you can see, and you can also see how much further. So here's the opening of the urethra for men. Here's the opening for women. The anus is literally right there. So you can see the distance as well is very different. So that's why females will often have a higher rate of UTIs. But in older men, they will commonly get UTIs because of prostatic hypertrophy or urinary retention. Sometimes children will have congenital abnormalities that can lead to more common UTIs, and then some other common predisposing factors are incontinence, retention of urine, and then if you have direct contamination with fecal matter, of course, because E. coli. Okay, and then yes, some of the causes of infection that actually happen in the urinary tract. So any bloodborne organism, of course, because your blood ends up in the kidneys. Immobility, because we have the stasis of urine. So remember, urine is a great growth medium, and so if we have immobility where that urine is just staying there and not moving, bacteria will definitely start to grow. The vesicular reflex. So sometimes the bladder is supposed to empty, but sometimes you have a defective valve, and so that will leave residual urine. You can actually have an obstruction. So in prostatic hypertrophy, you can have it built up so much where you have your ureter blocked off, your urethra blocked off, and then you have a bunch of residual urine, and now we're worried about stasis again. So those are the common ways that your urinary tract can get infected. So again, with cystitis and urethritis, cystitis, you're thinking a bladder wall infection. And urethritis, obviously inflammation of the urethra. Um, the pain is going to be most common in the pelvic area, because it's probably right where you'd expect. But some of the symptoms will be dysuria, maybe urinary urgency, or they're going more, so the frequency, or nocturia, so they have to pee at night. And then some of the more systemic signs you might see are fever, malaise, nausea, and leukocytosis, so increased white blood cells, and that's just because we have an infection. People with cystitis or urethritis and there's some kind of infection, you can expect them to have urine that's cloudy. So again, remember we said if there's white blood cells or proteins might make your urine kind of cloudy, and it might have an unusual odor. Then if you look at the urinalysis, you'll actually see the bacteriuria. You'll see the bacteria in the urine, pyuria, and then you might see microscopic hematuria. So you might see a little bit of blood in your urine. So when we're talking about urethritis, there's kind of two categories. There's gonococcal and non-gonococcal urethritis. So in gonococcal, obviously we have Neisseria gonorrhea. That's the one that's going to be causing the infection. And then in non-gonococcal, that can be, so like for example, chlamydia trachomatis. And so here we go. So cystitis, that's the actual inflammation of the bladder itself, whereas urethritis, the inflammation is in the urethra. Okay. So next up we have pyelonephritis. And so pyelonephritis can affect either one or both kidneys, and it can happen from the ureter. It can go all the way back up into the kidney. And what happens is that you have this purulent exudate that fills the pelvis and the calyces. So you can see this is how it's supposed to look right here. And then over here, you see how it's just inflammation and things are not shaped quite like how it should. Maybe the cortex is atrophied. We have a lot of inflammation here. The renal pelvis is a lot more distended than in this one. We have scarring. And so all of that can lead to, or from recurrent or chronic infections, can lead to those scars. And so eventually you'll have loss of tubule function. So your nephrons are not going to be functioning as well. You might have obstruction, and then you'll have collection of filtrate. So the urine will start to actually back up, because if you have an obstruction right here, the urine can't get out. And so what happens is that you have this buildup of urine, and that buildup of urine is called hydronephrosis. So you basically just drown your kidneys because the urine can't go anywhere, and so it all backs up this way. And then that can cause renal failure if it's left untreated. So for pyelonephritis, it's going to be all the signs of cystitis, but we're adding in also the pain associated with renal disease, which is very specifically a dull or aching pain in the lower back or flank area. So basically, right where your kidneys are. Then you'll know that their pyelonephritis is giving systemic signs if you have a high temperature. And then upon urinalysis, it's going to be similar to a cystitis because we're still looking at infection. Only difference is you might see renal casts that are present. Remember, that's just a reflection of the renal tubule involvement. It makes all those cells kind of form the cast that look like this. And they slough off of the tubule, but you can see these casts. So how do we treat it? Trimethoprim sulfamethoxazole, or Bactrim, that's probably what you heard it as. Firadantin, Keflex, Dorbax, amoxicillin, this is a big one. Or fosfomycin to pregnant women specifically. Okay, and then for inflammatory disorders, we are starting off with glomerulonephritis. So there's a lot of forms of glomerulonephritis. So let's just look real quick. This is normal. And then this is glomerulonephritis. So itis, we know that there's inflammation, and glomerular, it tells us exactly where it is, the glomerulus and the kidneys. But one of the forms you can have comes with the presence of anti-streptococcal antibodies. So the question would say something like somebody comes in and they had complained of a sore throat, like, I don't know, 3 weeks ago, maybe a month ago. And then they come back and they start to have urinary symptoms. And so what happens is that they have developed these anti-streptococcal antibodies. So what happens is that they form this antigen antibody complex, and that activates our complement system. And remember, our complement system is what we use to destroy bacteria. And so because of that, because of the complement system, we have this inflammatory response that occurs in our glomeruli, and that causes increased capillary permeability. And so whenever we have that, this inflammation causes increased capillary permeability, and we'll start to see possibly things in our urine that we should not be seeing. So you might start to see cells in your urine, you might start to see protein in your urine, and that's not good. So basically what glomerulonephritis is a severe inflammatory response that causes congestion and cell proliferation. And with this, that will cause a decreased GFR, because obviously your kidneys will not be working as well, which will cause you to start to retain fluids and wastes. So yeah, damage to the glomerulus, it can cause hematuria as well. So the urine will become dark and cloudy, dark from the blood, cloudy from the possible cells. In glomerulonephritis, you can also see facial and periorbital edema. So this just means around the eyes at the very start. And then you sort of have a general edema that follows, because remember, our kidneys are not working as well. So we are retaining water. Elevated blood pressure, again, because of our elevated H2O, as well as increased renin secretion and decreased GFR. You'll have that flank or back pain, and then just general signs of inflammation and decreased urinary output. So there are some blood tests that you can see with this. So you'll have elevated serum urea and creatinine levels, because again, we're not able to excrete urea, so it just stays in our blood. You might see elevation of things like anti-DNase B, see those streptococcal antibodies, anti-streptolysin, anti-streptokinase, all of those. And then you might see complement levels that are decreased in renal inflammation. And then we talked about earlier metabolic acidosis. So that's if your renal tubules are not working quite how they should. And so you're not actually getting rid of some of those hydrogen ions. And then upon urinalysis for glomerulonephritis, you can expect to see protein and blood in the urine, as well as red blood cell casts. But there will be no evidence of infection, because that's not necessarily the problem. The problem is just a massive amount of inflammation in the area, but not necessarily infection. So the treatment for this would be to restrict sodium as much as possible, because you're trying to not to retain water. Decrease the protein and fluid intake, because you're not able to adequately filter it at the moment, so you don't want to keep overwhelming your body with it. And so the drug treatments will be glucocorticoids to reduce inflammation. Just remember to watch out on type 2 diabetics because glucocorticoids will increase blood sugar, and antihypertensives. So this kind of just goes through what I was talking about with the post-streptococcal glomerulonephritis. So that's showing you what happens if you're looking kind of down the scope of the glomerulus. All right. Then we have nephrotic syndrome. So nephrotic syndrome is where we have an abnormality in the actual capillaries of the glomerulus. And so because of that, we have increased permeability. So that means we have proteins, cells maybe that are getting through that they shouldn't be, as well as large amounts of plasma proteins. And so all of those can escape into the urine, and that's not where they're supposed to be. They should be in the blood. And so it can be idiopathic in children 2 to 6 years old, so you might not know why. But it can also be secondary to SLE, so that's just lupus, or exposure to nephrotoxins, and some drugs will actually cause it as well. So the pathophys of nephrotic syndrome is that we have hypoalbuminemia with decreased plasma osmotic pressure. So remember, albumin, that is a plasma protein that causes increased plasma osmotic pressure. So keeps fluid in the blood. But in hypoalbuminuria, you don't have enough. And so because of that, you have decreased plasma osmotic pressure. And so that can lead to generalized edema because you have less of that sucking pressure. And so the fluid, instead of being sucked into your blood like this from albumin, it stays in your tissues, which causes edema. But the blood pressure will actually remain low or actually normal. But it kind of depends on those angiotensin 2 levels. You'll have increased aldosterone secretion in response to reduced blood volume. So remember, aldosterone causes sodium and water reabsorption. So if we're doing that, we are increasing our blood volume directly. And then in this, you can also see high blood cholesterol, lipoproteins in the urine, and then the urine can actually have a milky-ish appearance, and that's because of all those lipids in the urine. So again, the signs and symptoms are protein in the urine, lipids in the urine, or those casts, massive edema, and then sudden increase in girth. That's because of the edema. So the treatment for this is glucocorticoids, again, to reduce the inflammation, but you just have to watch out in type 2 diabetics. ACE inhibitors, so trying to antihypertensives, trying to lower the blood pressure, because let me draw this out one more time, just in case. So we have angiotensinogen, gets converted to angiotensin 1, it's converted to angiotensin 2. So an ACE inhibitor, we're knocking this area right here, which will decrease angiotensin 2, which decreases vasoconstriction. So that's how that works. But it can, for as far as specifically for nephrotic syndrome, it can decrease the protein loss in the urine. And then, sodium intake may be restricted. And so now we're going to talk about actual urinary tract obstructions. So urolithiasis, hydronephrosis, we talked about that a little bit, and then tumors. So a urinary tract obstruction can happen in a few different places. And it can be all kinds of things. So like, for example, we can have a blood clot that will cause just a little tiny obstruction. We can have a stone, so kidney stones, can cause an even bigger obstruction. You can have a tumor. So all of these things, anything that will basically block the flow of urine. And so Urolithiasis or calculi. Most people just know this as kidney stones. And so these can develop anywhere in the urinary tract and they can be small or large. But what we see is that they tend to form with excessive amounts of solutes in the filtrate. So maybe high sodium or high glucose. Insufficient fluid intake, so dehydration can be a major factor for calculi formation, and then obviously urinary tract infection. But the manifestations only truly occur whenever we have obstruction of blood flow. So whenever we have obstruction of blood flow, remember urine is a good growth medium for bacteria, but also urinary stasis, and so that can lead to infection, hydronephrosis. So that's whenever, say, we have an obstruction here, all that urine can't go through. So it backs up into the kidney, and then you just kind of drown your kidney basically. And then that can lead to eventual atrophy. And so usually these calculi are going to be composed of calcium salts that have, if you have, you'll have high urine calcium levels, and it doesn't take a whole lot for them to form when they have highly alkaline urine. And so the uric acid stone, so we have hyperuricemia. So you can expect to see this in people that have maybe gout. Maybe they eat a high purine diet or they're on cancer chemo. Especially with acidic urine, you can find uric acid stones. They can be struvite or cystine stones, but it really just there can be a whole range of different types of stones, but the type really just depends on the predisposing factor. And so, unfortunately, stones that are in the kidney or the bladder, they're usually going to be asymptomatic, but frequent infections kind of can lead you to go to the doctor and start an investigation. Flank pain, also, that's just a really odd place to have pain. And so, if you do have it, it could be being caused by distension of the renal capsule. Then renal colic can be caused by obstruction of the ureter. So that's what we talked about. So intense spasms of pain in the flank area that will go to the groin, kind of radiate. And unfortunately, this pain will last until the stone either passes or gets removed somehow. And then one thing that you'll hear people that have any kind of obstruction or a renal calculi is they might have nausea and vomiting, cool, moist skin. So you might hear them say cold sweat with a rapid pulse. And so if you do a radiological examination, you'll be able to actually see that kidney stone. So the treatment for this is that the first one is just time. So hopefully in time it'll pass by itself. If it's just really jammed in there and it's not wanting to get shaken loose, you can use a extracorporeal shockwave lithotripsy. Basically, you just kind of shoot sound waves in and try to just kind of jumble it up a little bit and knock it loose. You can do a laser lithotripsy. Some drugs can kind of be used to help dissolve the stone. It won't like dissolve it completely, but kind of help dissolve it. Or worst case scenario is surgery. And so you can prevent this to treat the underlying condition. So maybe it doesn't have to be a low salt and low glucose diet, but don't overdo it. If you want to adjust the urine pH, so again through dietary modifications, and then avoid dehydration. So make sure that you have adequate amount of fluid intake. So hydronephrosis, it's a secondary problem. So that means it's a problem that's going to be caused by something else. So the main problem is that we have urine that's backed up into the kidneys. And so, like I said, we're basically drowning our kidneys. And so our kidney gets swollen. So that can come from an obstruction. So maybe kidney stone gets stuck here, and then we have all of our urine that's backing up. Can come from tumors and untreated prostatic enlargement, maybe developmental abnormalities. So maybe the obstruction is that the ureter is too small, like this. It's frequently going to be asymptomatic, especially in the early stages. It can be diagnosed just by imaging or a renal scan. But if you don't remove it, it can lead to renal failure because your kidneys cannot operate like this. So that's what happens right there. And then, so tumors. So, one second. All right. So, renal cell carcinoma. So, renal cell carcinoma is going to be the primary tumor coming from the tubule epithelium, most often going to be found in the renal cortex. Um, in the early stages, you will typically see symptoms. So, the problem here is that it's heavily prone to metastasizing. So, it can come from the liver, the lung, the bone, the CNS. It occurs more frequently in men and smokers. Unfortunately, the way you treat it is to just remove the problem completely. So remove the kidney. You might be able to do immunotherapies in some cases, especially if you catch it early. But the problem is the tumor is radio resistant. So chemo really doesn't do all that much most of the time. And so it will manifest as maybe painless hematuria initially. So either you can see like your blood, or not your blood, your urine, maybe it's a little bit like, maybe it'll be orange or slightly red tinged, or you might not be able to see it at all unless you look at your urine under a microscope. So you could have dull, aching, again, flank pain. You might be able to feel a mass. Unexplained weight loss, remember, that's always big in cancer. Unexplained weight loss, always think cancer. Anemia or erythrocytosis, or paraneoplastic syndromes like hypercalcemia or Cushing's. Then cancer of the bladder. So usually these are going to be malignant and come from the transitional epithelium of the bladder. So remember, transitional epithelium is where we have those kind of umbrella cells like this. And they're good because we can expand them to make them super big like this, or we can condense them to make them small. And so that's really useful in things like the bladder that always has to expand and then shrink down. So these are typically going to involve multiple tumors. You'll diagnose it via urine cytology. Early signs, again, hematuria, dysuria, have trouble urinating, and then infections are pretty common. And the problem really is that the tumor is invasive through the wall, and so it spreads to the pelvic lymph nodes. And once it gets into your lymph nodes, it has access to your entire body. So the predisposing factors for bladder cancer, one of the most common ones is chemicals. So aniline dyes, rubber, aluminum. People that work in like a lab about this, cigarette smokers, and then some of the you could have recurrent infections, which could expose you to a lot of bacteria. And so if you're damaging that transitional epithelium a lot, that could lead to mutations leading to cancer or heavy intake of analgesics. And the treatment for this is just taking out the tumor, so surgical resection, chemo, and then sometimes radiation if you catch it early enough. And then the vascular disorders. So nephrosclerosis, just remember sclerosis means hardening. So we have nephrosclerosis, that is vascular changes in the kidneys. So hardening of the vasculature that's in our kidneys, somewhat normal with aging. So like I said, thickening and hardening of the walls. And so what that does is that narrows the blood vessel lumens. So say that we have this, and that's normal. And then say a sclerose, it looks like this. So what happens, we have this smaller lumen right here, which will reduce the blood supply to the kidney. And we have reduction of blood supply to the kidney that will stimulate renin, which will activate RAS, which will increase our blood pressure. And then you'll have continued ischemia, which will lead to destruction of the renal tissue and then eventually chronic renal failure. All right, so hypertension in the kidneys. So again, what will happen is that we will have hypertension. So we'll have high blood pressure. And then what will happen is that the second step here is that we have decreased blood flow to the nephrons. So because of that, we have renin that gets released. Well, let me start off with this. So when we have decreased blood flow to the nephrons, that leads to ischemia, which leads to necrosis, fibrosis, and then that just kind of continues that pathway, which will eventually lead to chronic renal failure. But with decreased blood flow to the nephrons, we have renin that's released, which will stimulate the RAS pathway. And so with that, remember RAS ends in angiotensin 2, which is a strong vasoconstrictor. And so less space and more fluid for circulating blood, which will lead to increased blood pressure. And now we have the same problem. Or this causes sodium and water retention, increased blood volume, and increased blood pressure. So you see how all of these can lead to that. So nephrosclerosis can be a primary lesion that's developed in the kidney, or it can be secondary to essential hypertension. So hypertension, remember, high blood pressure does damage to your vascular endothelium, or the walls. And so you can eventually start to form kind of like scars, and that will harden the artery. So the treatment for this are antihypertensive agents, so trying to bring down the blood pressure, diuretics, trying to bring down the blood volume, beta blockers, trying to bring down the heart rate, and then reducing the sodium intake.
So for congenital disorders, we have a vesicular uteral reflex. So what this is where we have abnormal backward flow of
urine from the bladder into the ureters and the kidneys. We can have, in these congenital disorders, we can have agenesis, and that's where you just have failure of one kidney to develop in general. Hypoplasia, which is where it's underdeveloped. An ectopic kidney, so this is where the kidney and the ureter are out of the normal position. Funny story, my uncle actually has this, and he didn't find out until he was like 53 that both of his kidneys are on the exact same side. So they're just like this. And the doctor told him that they didn't want to do anything with it because everything was working fine and they've never had any problems. And if they were to actually move one, he might actually start to have problems. So he's just a weirdo. And then a horseshoe kidney. This is where you have the fusion of both of those kidneys together. Adult polycystic kidney. So typically this can be traced back to an autosomal dominant gene in chromosome 16. So there is a genetic component. Typically young adults and children, there's no real indications, and you start to see it around age 40. And what happens is that we have polycystic, so multiple cysts that develop in both kidneys, which leads to enlargement of the kidneys. So as you can see over here, but also you have to worry about compression and destruction of kidney tissue, and then eventually chronic renal failure. And so this can be diagnosed by abdominal CT or MRI. And here's just another picture. Wilms tumor. So this is a very common, or I won't say very common, but this is the most common tumor in children, coming from the genetic component. So defect in the tumor suppressor gene, specifically on chromosome 11. Usually going to be unilateral, but it's a large encapsulated mass right here in the kidney. And one thing you have to worry about with a Wilms tumor is pulmonary metastasis. And the problem is it may already be present at diagnosis. All right, and then last up, we're going to finish off here with renal failure. So acute renal failure, this is where something happens in a relatively short period. So remember, anytime it's acute, it's a shorter period, but remember the symptoms are usually worse. So the causes of acute renal failure can be acute bilateral kidney disease, maybe prolonged circulatory shock, or heart failure. So if your blood pressure is too low for too long, different nephrotoxins, or it could be an actual mechanical obstruction like we talked about. So again, if it's acute, typically going to have a pretty sudden onset. You'll have elevated serum urea, nitrogen, and creatinine. You also might see this as a BUN. Then also metabolic acidosis and hyperkalemia because your renal tubules are not working as well. So the treatment for this is to identify why you have acute renal failure in the first place. So identify the primary problem because you want to minimize the risk of further damage, so necrosis and permanent damage to the kidney, and then you might have to start dialysis to maintain homeostasis if the kidneys are not working. And then for chronic renal failure, this is where we have gradual, irreversible destruction of the kidney. So remember, the symptoms are usually lower, not as severe, but they last for a lot longer. They don't necessarily go away. So it's asymptomatic in the early stages, but it can result from any of these. So chronic kidney disease, maybe the polycystic kidney disease, low level exposure to nephrotoxins. So it might not necessarily make you sick right away, but if you're exposed to it for maybe 25, 30 plus years at a low enough dose, it could start to cause problems. And so what will happen is that we'll have a decreased renal reserve, so a decrease in GFR because our kidneys are not working as well. Creatinine levels start to build up because our kidneys are not filtering it as well. But again, there's no apparent clinical symptoms, and then you'll start to develop renal insufficiency. And so that's where the decreased GFR is about 20% of normal, so significantly hindered. Then we'll start to retain our nitrogenous waste, which will increase our BUN, our blood urea nitrogen. Excretion of large volumes of very dilute urine. So a lot, not too much is being filtered, but we have a lot of water being filtered. Decrease erythropoiesis, so that just means our kidneys are not working as well. They're not secreting that EPO for red blood cell synthesis, or elevated blood pressure. So in chronic renal failure, in end-stage renal failure, there's a negligible GFR. So the kidneys are basically just not working at all. We start to retain things like fluid, electrolytes, and waste. One thing they refer to in chronic renal failure is the 3 A's. So azotemia, so that's like an increased blood urea nitrogen, anemia, and acidosis. So anemia is from the decreased EPO. Acidosis is from the hit on our renal tubules. So you can see here, basically what they're showing you is that as you lose nephrons, your kidneys become less and less functional. And so the early signs for chronic renal failure are increased urinary output. Some general signs that are kind of non-specific and won't necessarily point you directly to renal failure right away are anorexia, nausea, anemia. You could put it on there, but typically the renal is not the first thing you think of. Fatigue, unintended weight loss, and then exercise intolerance. And something else you have to worry about is due to the increased waste that are building up and the altered blood chemistry, because our kidneys aren't working, you have to worry about bone marrow depression, which could also be leading to anemia, but then impaired cell function, and then obviously elevated blood pressure. And whenever we have a complete failure, so complete renal failure, we have oliguria, dry, pruritic, and hyperpigmented skin, maybe easy bruising. Peripheral neuropathy can lead to impotence in men or menstrual irregularities in women. Encephalopathy, CHF, or dysrhythmias, failure to activate vitamin D, uremic frost on the skin, or systemic infections. So all of those can come from chronic renal failure. And so the diagnostic tests for this are to check and see if they have metabolic acidosis that becomes decompensated. Azotemia, so that's a buildup of blood urea nitrogen, a worsening anemia, or check the serum electrolyte levels because they just may be all out of whack. So maybe hyponatremia and hyperkalemia, hypocalcemia, hyperphosphatemia. So your blood chemistry will tell you a lot about what's going on with your kidneys. So to treat this, again, all your systems are affected. It's difficult to maintain this homeostasis. So you can give drugs for the EPO. You can treat the cardiovascular problems. You can do dialysis and you can intake of fluid, but chronic renal failure is not a good place to be in. And so here's just a chart if you like charts better. All right, so here is chapter 19. I know you guys are really stressed right now with all your exams piling up, so most people decided not to stay, which is totally fine. Just posting this so that you guys at least do have a lecture for this content. So just a quick review of the male reproductive system. So we've got the testes that perform spermatogenesis, so formation of sperm. We've got the epididymis, that's where we have the sperm actually maturing in that area. So this kind of little tail looking figure right here. Then we have the vas deferens. So that is the actual transport of sperm to the urethra. So the vas deferens is also called the ductus deferens. Then we've got the seminal vesicles, these little areas right here. And so your seminal vesicles are responsible for nourishing the sperm. Then your prostate gland, that has secretions that actually balance out pH because the vagina is pretty acidic. And so we have to gain these secretions from the prostate that will balance out that pH. Then we've got our Cowper gland, so our bulbourethral gland, that secretes alkaline mucus, again, trying to help the sperm survive in the low pH of the vagina. And then the penis is the eventual ejaculation of semen. And so I don't think that you'd get it for this exam, but just in case you do, a mnemonic that I heard for the pathway of sperm. If you're ever asked this, you can remember 7. So for the pathway of sperm, we've got the seminiferous tubules. So those will be kind of in the testes. Then we've got the epididymis. We've got the vas deferens, also called the ductus deferens. So we've got the ejaculatory duct. The N actually stands for nothing. It's just like a placeholder. And then we've got urethra and then penis. So that is the pathway of sperm, starting in the seminiferous tubules, leading to ejaculation from the penis. So this is just a side. So this is from the front right here. And then this is from the side. So the male hormones, it's not quite as in depth. I hate to say in depth, but not as involved as the female reproductive system. But for the male hormones, males also have FSH and LH. So FSH is going to be initiating that initial spermatogenesis. So where we're forming our sperm. Then luteinizing hormone, that's going to be responsible for our testosterone production, which is very high usually in males, especially around like the puberty age. And then that testosterone that gets formed from luteinizing hormone goes on to further mature the sperm. We develop sex characteristics, protein metabolism, muscle development. So pretty much everything you expect to see in like a puberty aged male, that is the role of testosterone. And so sometimes you can have congenital abnormalities of the penis itself. So that's where it's actually physically something is wrong and misshaped. So epispadias is where you have your urethral opening, but it's either on the ventral or the upper part of the penis right here. Whereas hypospadias is underneath. And so that's actually how I remembered the two, is that hypo usually means under or beneath, and that's where we have is under the penis, you have the urethral opening. And then you have Peyronie's disease, and so that's where you actually have a bend in the penis. Sorry for the not safe for work picture there, but I wanted you guys to at least see what it really looks like. So that's Peyronie's disease. And so all of these conditions can, of course, lead to incontinence. This one especially high infection rate or erectile dysfunction. So the treatment is surgical reconstruction. There's no medicine that will fix this. And so as we're kind of just starting on this disorders of the male reproductive system, we're going to talk about disorders of the testes and the scrotum. So cryptorchidism, a hydrocele, spermatocele, and then finally a varicocele. So cryptorchidism, this is where basically the testes do not go down into the scrotum properly. So what happens is that the testes in males, they start to actually form up in the abdomen. And then as we go, as they progress through puberty and as they're born, they progress through puberty, I should say, it slowly makes their way down and then out of the body. Okay, so in cryptorchidism, you don't have this. They don't come down. And so we don't really understand why, but you can have something called ectopic testes, and this is where the testes are going to be positioned outside of the scrotum. And so that's dangerous because it can cause degeneration of your seminiferous tubules. And if you remember our little mnemonic, 7-Up, our seminiferous tubules is all the way up here. So you can see that if we're having problems with the seminiferous tubules, the chances are that the sperm finally actually reaching ejaculation outside the penis is probably going to be not that great if it even makes it there, because the sperm building process or synthesis is impaired. And then the risk of testicular cancer goes up a lot if it's not treated. There you go. There's just that picture. So the testicle remain in the upper scrotum, but then as we go through puberty, they drop down here, and this is the normal location right out here outside of the scrotum. Okay, and then next up we have a hydrocele, and so that's whenever we have excessive fluid that collects in the space between the tunica vaginalis of the scrotum, and so it has two layers. Here we go. And what happens is that fluid will collect right here when it's not supposed to, between the visceral and the parietal layers of the tunica vaginalis. And so it can occur as a newborn, so just born with it. Can be from something, so injury or infection, maybe even a tumor. But the problem is that it can compromise blood supply or lymph drainage in the testes. So you can see how big this hydrocele is right here. If this starts to compress any nerves or starts to compress any blood vessels, you're going to lose supply of whatever it's crushing to the scrotum. So this is just a picture right here. So non-communicating hydrocele, but you can see right here where the fluid is building up in between these tunica vaginalis layers. And so that was a hydrocele. Now a spermatocele is where we have a cyst in the scrotum, and it contains the fluid and the sperm that develop between the testes and the actual epididymis. So it could be related to developmental abnormality, but unfortunately you do have to have this removed surgically. Again, you have the same sort of issues where if that starts to compress anything, it could lead to issues. And then a varicocele is where we have dilated veins in the spermatocord. So our spermatocord runs all the way down here. It is. And so what happens is that we have dilated or varicose veins in the spermatocord, and so you can actually see the dilation on the outside of the scrotum. And so the problem is that these veins, they lack the valves. Because remember, a vein has valves that keeps blood going one way. So if you don't have these, that blood can start to kind of build up. And so because of that buildup, that's what you're seeing. That's why the veins are dilated and have high pressure, is because all that blood is building up there. And so because of this, we have impaired blood flow to the testes, decreased spermatogenesis, and that also requires surgery. All right. So now a torsion of the testes, or a testicular torsion, like you'll probably hear out in the field. And so this is whenever the testes rotate on the spermatocord. So this is the spermatocord right here. What happens is sometimes the testes will get rotated around them like that. So when that happens, you start to compress the arteries and the veins. And anytime we have compression of blood flow, we have to worry about ischemia developing. And then obviously the scrotum will swell just because we are cutting off blood supply and there's blood building up behind wherever it's twisted at. And so the real problem occurs if the testes become infarcted, and from not reducing that torsion. So it can occur pretty spontaneously following trauma, and then it can be treated manually or surgically. This actually happened to my brother, and it was treated manually, but sometimes it does have to be treated surgically because it can be pretty severe. Oh, here we go. And then here's a picture right here, so you can see how they just gets kind of wrapped up right here. And so whenever you wrap them, you have to remember you have blood vessels, veins, nerves, and so all of those are getting kind of trapped. And now you have to worry about the scrotum becoming ischemic. So for inflammations and infections, we've got prostatitis. So that's where you have an infection or inflammation of the prostate. And there's 4 kind of different categories. There is acute bacterial, there is chronic bacterial, there's non-bacterial, and then there's asymptomatic inflammatory. So in acute bacterial prostatitis, typically you're going to be thinking E. coli. That's your main organism. Sometimes it can be some other gram-negative bacteria, but for the most part, E. coli. symptoms are going to be just like typical infection symptoms. So fever, chills, having trouble urinating, perineal pain, the prostate might be tender. And so the treatment for this would be antibiotics, hydration, and pain relief. Then we've got chronic bacterial prostatitis. And so this is where you have a recurrent infection by the same organism. So recurrent infection, same infection. So some of the symptoms here might be like mild pelvic pain, a low grade fever. Recurrent UTIs is a big red flag. And so for the treatment for this would be long-term antibiotics and maybe give them some kind of supportive care. Then non-bacterial, so this is just inflammation. So we've got the inflammation, but without infection. So this is just inflammation. So it could be autoimmune, could be maybe it got chemically irritated, it could be like a pelvic floor dysfunction. So all of those could lead to pelvic pain, urinary frequency, discomfort with ejaculation if we're talking about males. And so since there's not an infection, the treatment for this would be anti-inflammatories, stress management, and then finally we have asymptomatic inflammatory. And so this is where we actually see white blood cells in the prostate fluid. But the big kind of defining characteristic of asymptomatic is that there's no symptoms. So we've got the white blood cells in our prostate fluid, but that's weird because there's no symptoms for it. And so usually whenever you find these, or you find this kind of prostatitis, it's usually going to be incidentally or accidentally. So like if somebody goes in for fertility or a cancer workup, they might find like, oh, you have white blood cells in your prostate fluid. And unless you start to get symptoms, honestly, there's no treatment for it. But so just the main kind of takeaway is that while they present a little bit differently, all of them can cause urinary retention or painful ejaculation, either of those. All right, so if we're continuing onto this, we did prostatitis. So everything we just talked about, the acute bacterial, chronic bacterial, non-bacterial, asymptomatic, those fall under category 1, 2, 3, or 4. And so I'll let you guys reread over this if you want to, but they didn't say anything in this that I didn't just tell you guys in that last slide. So, but couldn't hurt to maybe go over it one more time, quiz yourself. All right. So balanitis. So this is where you have a fungal infection of the glans penis. The glans penis is the upper part right here. And so this is an STD or sexually transmitted infection caused by Candida albicans. And if you remember, this is the same fungus that caused thrush in the mouth in example asthmatics who use their inhaler. And so the problem is you get these vesicles, and these vesicles actually turn into these like blotchy patches. It looks like a rash, and it causes severe burning and itching. And so the treatment for this is topical antifungal medication. But just remember, the problem with antifungal medications is that antifungal meds are made to go after and kill eukaryotic cells because fungi are eukaryotic. So sometimes you get symptoms that are outside of the symptoms that you had in the infection, but maybe they don't start until you start taking the antifungal meds. And that's because these antifungal meds, while they will kill fungus like Candida albicans, they will also kill or damage your cells as well. And then epididymitis or orchitis. So this is where you have an inflammation of the epididymis. So epididymis is this area right here that kind of surrounds the testicle a little bit. And then orchitis is where you have inflammation of the actual testicle itself. So epididymis is inflamed epididymis, inflamed testicle, orchitis. It could be a lot of different organisms that cause it, and age, history, sexual activity, all of those things matter. And so antibiotics are going to be the primary treatment for this. And so as far as the tumors go, we've got benign prostatic hypertrophy, cancer of the prostate, and then cancer of the testes. So in benign prostatic hypertrophy, you will hear this as BPH, especially in the field. Whenever you guys start rotations, you'll definitely see this. So it's very, very common. Up to 50% of men over 65 years old have benign prostatic hypertrophy. And what basically happens is that you have hyperplasia, right? But it's just of the prostatic tissue. And so because you have all that buildup of tissue, you can start to compress important structures like the urethra, or the urinary obstruction. And so it can lead to a lot of different issues. There has been some evidence that's related to estrogen testosterone imbalance, which could explain why it's so high in males. Well, besides the fact that females don't have a prostate, but what I mean is, why is it over 50% of men over 65? So that must mean that there is some kind of pattern that's occurring if it's that high of an incidence rate. But what's important is that BPH does not predispose to prostatic carcinoma. And so what this is, again, is just basically you have an enlarged gland. And the way males get this checked is they get their prostate actually palpated on a digital rectal exam. So that's the exam that every male hates. They always talk about it like it's the worst thing in the world. The problem with BPH is that it leads to very, very frequent infections or obstructions. And so if you have enough obstructions, have them often enough, it can actually distend your bladder and cause your ureters to become dilated because you always have that obstruction. Hydronephrosis. So if you guys remember, that's basically where your kidney just gets drowned because we have our ureter right here. Something's compressing right here, and that's causing all of the urine to back up and just flood out our kidney like this. And then obviously renal failure if this is not treated. So some of the signs and symptoms that we have for BPH are obstructed urinary flow, which could lead to hydronephrosis, hesitancy in starting urination, maybe there's some dribbling, decreased flow strength, pretty much everything that you associate with being an old man. So you have to pee a lot, maybe you're dribbling and you can't pee all that much, you're having trouble peeing, so you hesitate, have to pee a lot at night, or dysuria if there's an infection present. All of those are symptoms of BPH. And so the treatment is, there are drugs to slow down the enlargement, so to slow down that hyperplasia. You can give smooth muscle relaxers, kind of make sure that they're not staying contracted. And then you can give a combination of finasteride and digoxin, which will reduce the progression of hypertrophy, and then surgery lastly if there's just nothing else. All right, now we're going to talk about the bad C, with the big bad C word. So cancer of the prostate. So it's the most common cancer in men older than 50. So very common. The third leading cause of cancer death in men, with 1 in 6 affected. Predominant, or the tumors that predominate when we're talking about cancer of the prostate, is adenocarcinomas near the surface of the actual gland. And so one thing that they have found is that the more undifferentiated the tumor, meaning the less tumor protein markers that it has, the more aggressive that it's going to be. And so a lot of these tumors are going to be androgen dependent, and androgen is just a substance that's like pre-sex hormones. So both of these cancers are invasive and metastatic. Some forms are going to be more aggressive than others, pretty much like all cancers. So 5 to 10% are caused by just inherited mutations. So that's something that happened along their gene pool, and then some other causes, like we said, the androgen dependency might have something to do with it, increased insulin-like growth factor, or history of recurrent prostatitis. And so whenever you're actually feeling this, or whenever the doctor's feeling this, they might feel a hard nodule on the gland. There might be complaints of hesitancy in urination, or decreased urinary stream, maybe peeing more, or have a lot of UTIs. All of those can be the signs and symptoms. So for the diagnosis, you can look at serum markers. So you guys have probably heard of prostate-specific antigen, or PSA. So they can use that. I don't know the exact numbers, like for what's considered good, what's considered bad, but I do know that the higher this number goes, that's whenever they start to become more concerned. But you can also use ultrasound, biopsy, or bone scans if you're trying to detect if it's spread anywhere. And so the treatment, called a radical prostatectomy, so that's going to be surgery. You can do radiation with external or implanted pellets. So my grandpa actually had this done. They put these little pellets in his prostate, and then he goes and has radiation. And I don't really know how it works, but I mean he's been fine for like 5, 6 years now. So if the tumor is very androgen sensitive, then orchiectomy is effective. So obviously that's surgery, and then as well as anti-testosterone drugs. All right, and so now we're going to talk about cancer of the testes. So something scary about testicular tumors is that a lot of them are malignant. So we got about 1 in 300 people that are affected by cancer of the testes. It's very, very common, most common in young men. We see the number of these cases increasing, and it's probably because there's more self-reported testicular self-examination. So men are checking themselves more, and because of that, we're finding out that it's more common than what we believed. And so cancer of the testes can originate from either one cell type or it can be just kind of mixed in. There is something called a teratoma. And if you have not looked this up, please pause this right now and look it up, because these tumors are, they have a bunch of different germ cells, but these teratomas can actually have hair and teeth, and they are terrifying looking. So if you haven't seen one of those, please pause this and look it up. And hopefully you'll have the opportunity to see one in real life, because it's very, very interesting. And then some of these malignant tumors, they will actually secrete HCG or AFP, which serve as useful markers for diagnosis. And this is why sometimes people that might have, say they have cancer of the testes, they might show positive on a pregnancy test. And they might have a tumor that's secreting HCG, human chorionic hormone. And so the typical spreading pattern for the testes is that you're going to see them in the iliac and para-aortic lymph nodes. Then they'll slowly spread to the mediastinum and supraclavicular lymph nodes, and then to the blood. And then you get to the lungs, liver, bone, and brain. This is where it gets very bad. So this is where you're thinking stage 4, and the cancer has just pretty much taken over the majority of the body. And so this is our spermatic cord that always comes down. And so this is the malignant tumor right here. So you can see the clear difference between this skin or this area right here, and then you're looking at the tumor right here. So some of the causes for cancer of the testes will be a change in chromosome 12. So I don't think you really need to know this as much. You need to know just that it can be hereditary. Cryptorchidism is the predisposing factor. And then oddly enough, exposure to some herbicides and environmental agents can also be predisposing factors. So some of the signs and symptoms, the tumors are going to be hard and painless, typically unilateral. One of the testes may be enlarged or might feel heavier than the other, kind of a dull aching in the scrotum or the pelvis. You might see a hydrocele or epididymitis develop, and then gynecomastia, so that's just swollen breast tissue, occurs if the tumor is hormone secreting, right? So that makes sense, because if we are secreting a lot of sex hormones or the substances before sex hormones, then obviously we're going to have more. So the diagnostic test typically not going to be done on the testes, but if they have to, they'll do a biopsy. Again, they're looking for these tumor markers because a high HCG really shouldn't, in males, is not common. But ultrasound, CT, and then lymphangiography, that's where you look at the lymph vessels and the blood vessels to see exactly what's happening. So the treatment can be a combination of, so orchiectomy is the surgery, but radiation therapy or chemotherapy. And then sometimes, they put this note here, sometimes males will wish to donate sperm before they start treatment, because there might not necessarily even be anything wrong with their sperm, but whenever they come out of treatment, they might have problems. So if they donate sperm before, take them to a clinic, they keep them there, they might be able to have kids absolutely fine. But then they might not be able to have it afterwards. So, all right, so that was the male reproductive system. So now we're going to jump into the female reproductive system. Just a second. Okay. So the reproductive system, the female reproductive system. So the vulva is, let me find it right here. It's going to be made of the Mons pubis, and so the mons pubis is where you can expect to find like a kind of like a fat pad almost, like adipose tissue, but also you'll have hair covering the symphysis, the pubic symphysis. And then we have the labia minora and majora, so babies. And so both of those, that's the outer and kind of inner folds of the skin that they go back and down from the mons pubis. So if you follow this down, the mons pubis is up here, and then we've got labia minora, the majora is out here. All right, then we got the clitoris, which is the erectile tissue that is anterior to the urethra in females. So got this area right here. And then the vagina is the muscular distendable canal that extends upward from the vulva to the cervix. And you can't really, I mean, you can kind of see the opening here, but it'll be fine. Here we go. This is what I was looking for. So got the vagina right here. This is the tube that leads to the cervix. We've got our uterus, so that's the actual muscular organ that houses the fertilized ovum once it implants. The cervix is the opening into the uterus and the actual neck of the uterus. So again, we're looking all in this area right here. So we got our external and our internal os. And then finally, we've got our fallopian tubes that come from the ovaries and the uterus. You can't really see them here, but you can't see them here either. Here we go. So this is our fallopian tubes right here. And then we've got our ovaries. So ovaries are a big gland right here for the female reproductive system. So these are what actually produces our ova or our egg cell, as well as our estrogen and progesterone hormones, which are insanely important, especially in the menstrual cycle. And then we've got our breasts. So obviously the glands that produce colostrum and milk for the newborn, and then adipose tissue. So for the hormones in the menstrual cycle, so usually it's going to be one cycle will be from 21 to 45 days. Most females are not exactly like on the dot regular if you ask them, just because it can be influenced by so many different things. But for the most part, 21 to 45 days is a decent average, I would say, for the population. So the first 5 days are going to be just menstruation. So that's where we're going to be taking off that cell layer, menstruating it. Then we have our endometrial proliferation. So obviously we need to replace what we just shed off, as well as the production of estrogen. That kind of varies depending on the day. Then we've got our ovary and our follicle that actually matures. And then we have our huge surge of LH. And so this is actually called the LH surge. And whenever females have this huge LH surge, that's whenever we have ovulation. So this is just a little thing that I found for the menstrual cycle. If you can memorize it, I say go for it. It's fascinating. The female menstrual cycle and hormone cycle in general is absolutely amazing. So that graph is for you if you want to look at it. And then as I kind of talk through it, you can kind of trace where the hormones are going up, where they're going down. So like I said, the first couple days, first 5 days or so, it's just menstruation. So we're going to be thinking a lot of bleeding and sloughing off. So that's what they're showing right here. But then after day 5, we start to have proliferation of that endometrial lining. So in the menstrual cycle, we have this follicle, and it's going to eventually become the corpus luteum, and the corpus luteum will produce our progesterone. So in days 12 to 14, so right about here, you start to see vascularization of the endometrium. And that's because we're bringing blood supply to that area, because say this is the endometrium, like they're showing the size of the endometrial lining. So you're going to start doing this 12 to 14 days prior to the onset of next menstruation. That way, if the egg cell were to get or if it were to get fertilized, it'll have the blood flow in the area to implant. Now, what happens majority of the time is we will have implantation that does not occur. And so what happens, and what we're seeing is here. So we have this giant LH surge. I hope you guys see that right in the middle, right at about day 14. You have the LH surge. This is where the ovum, which is this guy right here, shoots out of there, like that, shoots out of the follicle. And so then after that, the egg cell does its thing, but the actual follicle itself starts to degenerate. So the corpus luteum atrophies, that's what we're seeing right over here. We have our uterine muscle contracting, which causes the ischemia, and then our endometrium degenerates again. And so that's whenever we see right about here. And so some structural abnormalities of the female reproductive system. So the normal position of the uterus is to be slightly anteverted, which means slightly coming forward a little bit, and anteflexed. So this is the normal position right here. So little slightly anteverted. And then the cervix is obviously downward and posterior. That's what we want because for sperm to enter, it needs to be facing downward. Now, a few things can happen. We can have retroflexion of the uterus. And so, well, actually, there's three different ones, but retroflexion right here. So we tip our uterus posteriorly. So you can see where these dotted lines where it's supposed to be versus what's actually happening. So it can be excessively curved or bent. But this can cause back pain, dysmenorrhea, so problems with the menstrual cycle. And then it can also cause infertility because you have to think about it. If it's supposed to be facing this way and it's like bent over, it's not going to be working as well. And so you might not be able to conceive. And so this right here is just a little from the side kind of showing you. Next thing you can have is uterine displacement or prolapse. So a first-degree prolapse is if the cervix actually drops into the vagina. So this is a healthy uterus right here. What you can see is that it's starting to slip right there. So that's the first degree if it starts to slip. Second degree gets a little bit more serious. If the cervix it's going to lie at the opening of the vagina. So you could almost like borderline see part of the cervix, and that is not good. So the body of the uterus actually goes into the vagina. And then a third degree prolapse is where the uterus and the cervix actually completely go through the vaginal opening. So you would be able to see the cervix just on naked evaluation. So the early stages of this can be pretty asymptomatic, but then obviously the advanced stages can lead to discomfort, infection, decreased mobility. So this is what we're seeing right here is that this is where it's supposed to be, slightly anteverted, but we can have it where it slowly slips down and then eventually goes out of the vaginal opening completely, and that's called a uterine prolapse. So just continuing it, our structural abnormalities, you can have a rectocele, and this is where you actually have the rectum that starts to protrude into the posterior vagina. And so that can cause constipation and pain because obviously you're blocking off a part of the rectum. We can have a cystocele. That's where we have part of the bladder that goes into the anterior vagina. And so UTIs are a big one here. And so if either of these are severe, they will go ahead and do the surgery to treat it because they want to increase the support of the pelvic ligaments because any structural abnormalities are going to be hard for your normal ligaments because they're not meant to hold things in a certain way. And so you can see here where the bladder is actually bulging into the vagina, and then the rectocele right here is where you have the rectum bulging into the vagina. So either one of those, not good at all. And so the menstrual disorders, so some of the menstrual abnormalities, we've got amenorrhea, and anytime you see A, that just means without or none. So we have no menstruation, can be primary or secondary. Primary, we're going to be thinking genetic causes. Secondary is going to be more hormonal imbalances. Dysmenorrhea, so that's painful menstruation. So it can be caused by excessive release of prostaglandins from endometrial ischemia. Remember, because this endometrial ischemia is normal, but if it's excessive and it's too much, that can lead to pain. Typically going to be a few days after menses and will last a few days, and then NSAIDs do offer some relief for dysmenorrhea. Premenstrual syndrome, so about 1 week before the onset of menstrues, you can start to have sort of abnormality. The pathophys is not necessarily known, but there could be a couple different forms. But the main problem in premenstrual syndrome is that you have everything that you'd expect with like the menstrual time. So breast tenderness, weight gain, abdominal distension or bloating, irritability, emotional liability, sleep disturbances, depression, headache, fatigue. All of these are completely normal in a female menstrual cycle. But the problem is it's coming 1 week before the onset of menses. And so the treatment is very individualized. So it can be things like exercise, limiting salt intake, oral contraceptives. people, a lot of the time they hear oral contraceptives and they think that a female or girl is automatically having sex, but that's actually very, very untrue. There's girls that start oral contraceptives very, very young, way years before they're even sexually active, and that's to help them if they have any menstrual abnormalities. And then as well as diuretics or antidepressant drugs. So if there is any abnormal menstrual bleeding, typically it's from a lack of ovulation. That's not to say that a hormonal imbalance doesn't exist, just means that it's just probably not a lack, or there probably is a lack of ovulation. So menorrhagia is going to be just that you notice maybe an increased amount and duration of flow. So maybe you're bleeding a little bit more than what you usually do. Metorrhagia is bleeding between cycles. Polymenorrhea is where you have short cycles of bleeding but it's less than 3 weeks. And then oligomenorrhea is long cycles of more than 6 weeks. And so this one is obviously very, very dangerous. I mean, polymenorrhea can be too, but you have to watch out for anemia with this one because you're losing a lot of blood. All right. So everyone's probably at least heard of this one before. So endometriosis is where we find endometrial tissue outside of the uterus. And so the problem with this is that this tissue still responds to its cyclical hormone changes, right? Because we still have the menstrual cycle. So all of our endometrial tissue will respond to that. But if we have this endometrial tissue outside of our reproductive system, it's still going to respond the exact same way. And so the bleeding will lead to inflammation and pain because we're not supposed to be bleeding in this area. You can start to get fibrous tissue around some important structures just because we are building the scar tissue. Don't exactly have a cause thought to be congenital, but the treatment is hormonal suppression. And then if you can find the ectopic tissue, actually removing that from the body. Candidiasis, so that's a form of vaginitis. That is not an STD. So again, caused by the fungus Candida albicans. So talked about this guy twice already. Opportunistic infection by normal flora of the vagina. So antibiotic therapy, pregnancy, diabetes, reduced host defense, any of those can cause a Candida albicans overgrowth. And the reason antibiotic therapy does is because our normal flora, or not our normal flora, a female's normal flora usually fights off, well, not fights off, but it keeps this fungus at bay. But if you take antibiotics and you lower the normal flora, then you can have an overgrowth of Candida albicans because you don't have the normal flora keeping this at bay. And so that's why they say you really should be careful and not just take antibiotics for anything because you're just contributing to possible overgrowth by these types of organisms. So it causes red and there's going to be red and swollen. The mucous membranes will be specifically and intensely pruritic and thick. And so white, like curd-like discharge can go into the vulvar tissues. The good news is that antifungal treatment pretty much takes care of that. All right, and then we've got for infections our pelvic inflammatory diseases. So this is where you can have an infection of the uterus, the fallopian tubes, or the ovaries. So any of those can be acute or chronic. So just remember, in general, if it's an acute syndrome, typically it's going to be more severe, but it's for a shorter time period. Whereas chronic is typically going to be less severe, sometimes even being asymptomatic, but you're in it for the long haul. So infection is typically going to originate from as an ascending tract infection from the lower reproductive tract. So it can occur because of bacteremia, so bacteria in the blood. Majority of infections are going to come from STDs, non-sterile abortions, or childbirth. So here we go right here. That's just a picture of what this looks like right here. You can get vaginitis, cervicitis, salpingitis, peritonitis, oophoриtis, endometritis, any of those. It's just inflammation of any of those areas. And so what happens is that you have scarring of these tubes. And so because you have this scarring, it basically drops or raises your risk of infertility and ectopic pregnancy. And so the potential acute complications of having this is, like I said, peritonitis, pelvic abscesses, or septic shock. That's a very dangerous one. And so typically with this, pelvic pain is going to be your first sign. So you might see like your temperature might be increased. You might see guarding, nausea and vomiting, leukocytosis, fluid discharge. But typically it's okay as long as you get aggressive antibiotic therapy in the hospital because whatever is causing this infection is typically going to be a pretty nasty one. All right, now let's talk about our benign tumors. So leiomyoma, ovarian cyst, polycystic ovarian syndrome, and then fibrocystic breast disease. So leiomyoma or fibroids, these tumors are benign and you will find them in the myometrium. So remember, myo means muscle. So it's going to be in this very, very muscular layer right here. Very common during the reproductive years. They're going to be named based off where they are. And so usually these leiomyomas are going to be, you'll have multiple well-defined and like unencapsulated masses in certain areas. And so it could cause abnormal bleeding. It could mess with implantation depending on the area. Usually going to be asymptomatic until they grow large enough to start causing problems, and they can be treated with therapy or surgery if they're bad enough. Then we've got our ovarian cysts. So there's so many different kinds. The physiological type will last about 8 to 12 weeks, and then they'll disappear and without complications. They'll come and go just like that. Typically going to be multiple and small, but they will have fluid inside of them. Bleeding can occur, and so typically you'll see more inflammation occur then. Ovarian cysts require surgical intervention, and then whenever you're trying to identify it using ultrasound or laparoscopy, just to ID it. All right. Then we got polycystic ovarian disease. So this is where the follicles of your ovary start to actually get a fibrous kind of capsule around it. And whenever it thickens, that's when you start to have problems. And so it can be hereditary. So maybe your genes code for an increased risk of developing these fibrous capsules. And so typically you'll have an absence of ovulation, or you'll be the female will be infertile. You might see a hormonal imbalance, amenorrhea, so just having no menstrual cycle, hirsutism, and so the treatment can be surgical. So you can do a surgical wedge resection. There is some pharmacology that you can use, and then just in case you don't know what hirsutism is, this is basically I won't say too much, excessive hair growth for women. And it's just this extra growth of very, very dark and coarse hair. So that's a symptom there. And so this is a surgical view of the polycystic ovaries here. All right, and then fibrocystic breast disease. So obviously you can see where all these cysts are developing in the breast tissue here. So there's a broad range of changes and densities that actually classifies the fibrocystic breast disease. Sometimes they'll be cyclic, so there'll be nodules or masses that will occur and then they'll go away. Very cyclic. Problem is, if these atypical cells, if they're present and they persist for a while, you have an increased risk of possibly having breast cancer. Increased density, so the more dense they are, makes breast self-examination difficult. And then, interestingly enough, we saw increased cystic masses with caffeine intake, and everybody drinks caffeine. So just be aware of that. And then, so some of the malignant tumors we have, so carcinomas of the breast, cervix, and the uterus, and then finally ovarian cancer. So carcinoma of the breast, after age 20, the incidence increases. Typically between 50 and 69 is where you're going to see carcinoma of the breast. Typically going to be unilateral. The earlier that it onsets typically means the more aggressive that it's going to be, not always. Some of the different types, so usually they're going to arise from your ductal epithelial cells that are in the breast tissue, but sometimes you can get metastasis, especially early in the course of the disease. And remember, your lymph nodes are like the highway to your body. So if you get any tumor cells in your lymph nodes, they have access to pretty much everywhere. And then something additional for sure is that anytime you have presence of estrogen or progesterone receptors on the tumor cells, it influences the treatment because you're going to have some extra steps because these receptors are going to respond, and that tumor could be altering the normal biology. Then we've got carcinoma of the breast. So the biggest predisposing factors for this are if you have a first-degree relative with carcinoma of the breast, strong genetic predisposition, specifically these genes BRCA1 and BRCA2. I did some research on BRCA1 and artificial sweeteners in undergrad, and what we found is that while the artificial sweeteners did not necessarily induce cancer, like it didn't start the cancer, in almost every single cell line that we did, those with the artificial sweeteners, if the cell line already had cancer, it exponentially sped up the growth. Now, again, that's just one isolated experiment in a random undergrad, but for what it's worth, we did see that. So lack of exercise, smoking, high-fat diet, all of those are predisposing factors. Radiation is always a predisposing factor for cancer, and then cancer of the uterus, ovaries, or pancreas because it can easily spread to the breast. And so some of the signs and symptoms, change in mammograms. Women, please get your mammograms. I know it's not exactly the most comfortable thing in the world, but it can literally save your life, but it can also save you from a lot of headache and pain. So some of the initial signs are single, small, and hard, painless nodules that you might find on the breast. This is ideal if you find this. Obviously, not having it is ideal, but finding it in this stage is ideal because it means you're finding it early. Because some of the later signs and symptoms will be like your breast tissue will actually start to get distorted, maybe dimpled skin, discharge from the nipple. This is all signs that the cancer is more at a more severe stage. And so usually you'll need an ultrasound or a needle biopsy to confirm the diagnosis. And so the course of breast cancer, by the time the tumor gets to 1 or 2 centimeters in diameter, you already have to start worrying about it spreading. Axillary lymph node involvement. So these axillary, that's just the ones in your armpit. And obviously that's the lymph nodes are right there. They're right next to the breast tissue. And so a lot of the time, once we have this cancer that has metastasized, the secondary tumor we can expect will be either in the bone, the lungs, the brain, or the liver. That's typically where it ends up landing at. So you can see that right there. We have this primary tumor. Some of the cells break off into a blood vessel or the lymph system, and then they just spread everywhere. And so the treatment can be a lumpectomy or sometimes just removal of the breast. A lot of women, actually, they opt to just go ahead and have their breasts completely removed and then remodeled. And I'm going to be honest, you can't even tell most of the time that anything has happened. But the plus side of the removal is that if the cancer hasn't spread and you're removing the cancer, and they know that it hasn't spread, the odds of it coming back are not real high because you don't even have real breast tissue for it to come back in. So personally, I advocate for removal of the breast if you start to even think that you might have any problems, because it could save your life. So you can remove the lymph nodes depending on the stage of the disease. Tissue biopsy is important because it's going to tell you a lot about the tumor itself. So there's specific growth factors that might be on somebody's tumor and not the other. But something that's fairly new, and I think you guys are actually entering the field into a really interesting time, because we're able to actually, from a tissue biopsy, we can do a bunch of tests on the tumor, and then you can take the patient's cells and run their DNA, run their entire genetic code. And we're starting to get to where we can actually design specific drug treatments and chemotherapy that for any random person, it wouldn't necessarily be all that helpful. But to this certain individual, because we're targeting their specific genes and their specific genome, it's actually showing some promising results. So that's really cool. And then radiation therapy can be done before or after surgery, just to kind of make sure that you get everything. And so for the drug therapy, we've got hormone blocking agents. So think tamoxifen, raloxifene, tormofen. Key word here is fen. I don't think you're going to really have any pharmacology, but just in case. Estrogen receptor blockers. So fulvestrant blocks the estrogen receptors on the cancer cells. And so what it actually ends up happening is that this signals the cell to destroy the receptors. And so that's what we want. Then you can have drugs that just straight up inhibit estrogen production. So anastrozole, letrozole, exemestane. Again, I would not pay too much attention to the drug names. I don't think you're going to get much of that in here. That's more farm. But I would definitely know that they exist. And then here's just some other targeted drug therapies. I'm not going to go over them with you, but just one thing for you to always kind of know is that anytime you see MAB at the end, so you'll see that it's here, there's quite a few. MAB is a monoclonal antibody. So that's all that stands for, is MAB. Then we have carcinoma of the cervix. So this is why the HPV vaccine in males and females too, but males are kind of like a super spreader. And so this is an STD, but if you take the vaccine, it dramatically lowers obviously the risk of HPV, but the even kind of bigger and larger results are a lower incidence of cervical cancer caused by HPV. And so this is why females get routine pap smears, is what they take these, they swab the inside of the cervix, they take these cells and they can actually look at them and they can tell by their morphological changes, what they're doing, the stage of the disease. And so typically you're going to start this around age 20 or whenever the typical sexual activity starts to begin. And then you do at intervals discussed with your doctor. And so this is what a positive pap smear, just an example of what a positive pap smear looks like. And so for the pathophys is the entire course of the disease. Early, we see dysplasia of cells. So this is just abnormal cells from the cervix that they just don't look like all of the ones that are around them. If you have an in situ tumor, these are going to be located mostly on the mucosal surface. You can start to see invasion to the submucosa, and then we start to see spread there, and then late metastasis. So the risk factors are going to be, again, under 40, so strongly linked to the STD infection HPV. Risk factors having multiple partners because you have an increased risk of coming across HPV. Sexual intercourse that begins too early, so maybe thinking early teenage years, and then smoking, and if there's a history of STDs. Then carcinoma of the uterus. So this is most common, oddly enough, in postmenopausal women. So this is probably going to be, I say older, but don't get too offended. Any women over 50 years of age, that's considered postmenopausal. That's where you're going to be seeing majority of these cancers. And so an early indicator is painless vaginal bleeding or spotting. And so a lot of the time a female postmenopausal, not expecting to have vaginal bleeding or spotting. And so they'll be like, why, what's happening? And they'll go to look and they'll see that they have carcinoma of the uterus. And so something that is the risk factors is a high dose estrogen hormone treatment without progesterone. Then obesity and diabetes, of course. So unfortunately, a pap smear does not detect carcinoma of the uterus. Typically going to come from your glandular epithelium, and it's slow growing, but it's invasive, and that's the problem. Slow growing means the symptoms are not really going to show as quick, so it's not going to be as abrupt. You might not notice them, and it's invasive and that's bad because if you don't know something's growing, and it's very invasive, it could be spreading everywhere. And so we stage this cancer based on the localization, and then the treatment is surgery and radiation most commonly. All right. Ovarian cancer, unfortunately, there's no reliable screening available. So typically it's just going to come across it from a pelvic exam. You find a large mass, transvaginal ultrasound, you can actually see the mass. This is considered a silent tumor because they're often not diagnosed in the early stages. And so there's actually research going on now to test for different serum markers just to be able to diagnose it. And then there's a bunch of different types that actually vary in aggressiveness. And so the risk factors are going to be obesity, and then there's that BRCA1 gene again, early menarche, so early menses, and then use of fertility drugs, talc powder, asbestos. I don't really know that that's all that common, but it's been shown that oral contraceptives that contain progesterone are actually somewhat protective against ovarian cancer. So just another reason that somebody might be on oral contraceptives and not necessarily mean that they're engaging in sexual activity. And then again, surgery and chemo for ovarian cancer. All right, so infertility is a sad and touchy subject to a lot of people. And so it says can be a female condition, but obviously can be a male condition too, or combination of both. So usually it's going to be associated with hormonal imbalances, the age of parents. So we've started to kind of see, like if you look at a graph, people are having kids a lot later, which is not necessarily a problem. It's just that whenever you start having kids into like the 40s, 50s, 60s, that's whenever you have an issue because your body is not as good as what it used to be able to do. Then structural abnormalities can cause infertility, like we've talked about, infections, chemo, toxins, environmental factors, or it could just be idiopathic. So we don't really know why you're infertile, but just. So there's a few different kinds of STDs: bacterial, viral, and protozoan. So your bacterial infections, just to name a few, are, so you can have chlamydia, gonorrhea, or syphilis. Some of your viral infections are like genital herpes or genital warts, and then some of your protozoan infections are like trichomoniasis. So for those chlamydia infections, chlamydia is incredibly common STD caused by Chlamydia trachomatis. And so in males, it typically they'll develop urethritis and epididymitis, like we talked about. So just inflammation and swelling. So including dysuria, itching, might have some white discharge from the penis, and then you could also have a painful swollen scrotum. Could be fever, inguinal lymph nodes, and then in females, often be asymptomatic until you have infertility or missed period. So newborns can actually be infected during birth, and that's pretty scary. Gonorrhea is called by Neisseria gonorrhoeae, and so most of the strains, the problem here is that they become resistant to penicillin and tetracycline. And that's due to just like a small amount. So say that you have a gonorrhea infection right here, and they're all right here, and you give somebody antibiotics, and it kills them all except for like maybe say one or two. These are penicillin resistant. But since you didn't kill these will go on to reproduce, and now we're reproducing a strain of antibiotic resistant bacteria, and so that's what's actually happening. Yeah. And so for gonorrhea, in a newborn, the eyes can be affected, and so that can actually cause irreversible damage and blindness, and they can cause septic arthritis. So the current treatment that we have for gonorrhea is kind of a dual system approach. So multiple antibiotics, because again, we want to avoid development of resistance. We're trying to avoid this. So if you hit the bacteria with one, wait a little bit, hit them with a different one, and then hit them with a different one, you're kind of hitting them from a bunch of different angles. So this is just a chart for anybody who likes the charts a little bit better. All right, so syphilis is caused by Treponema pallidum. This is a spirochete. If you don't remember that, that's the ones that kind of look like this a little bit. So in the primary stage, you start to get a canker at the site of the infection. So it could be in the genital region, the anus, or the oral cavity. You start to get like a canker sore. It's going to be pretty pain and firmless, ulcerated. So it's going to be about 3 weeks after you've been exposed. So you might not even really know what you've been exposed to. And then it typically seems to heal spontaneously, but the patient is still contagious. And so this is an example right here. This is the syphilis right here. This is the spirochete. So you can see how small it is because this is a cell right here. And so in the secondary stage, if it's untreated, you start to kind of come down with like a flu-like type illness with a widespread symmetrical rash that is self-limited, but again, still contagious. And then in the latent stage, this can be like many, many years later. Something important is that transmission can still occur. And then we have tertiary syphilis, and this is dangerous because this is where we start to see irreversible changes to our body. So we start to develop these gumas in the organ and major blood vessels. Hold on one second. And so gumas are just like kind of small, soft, non-cancerous growths. And so the organism can be transmitted to the fetus in utero. That's what we were talking about. That can cause blindness. A baby already born with tertiary syphilis those symptoms are not reversible. So that's going to be obviously the most sad. And so the treatment, obviously, multiple antimicrobial drugs, like we talked about, and then you have to worry about an increase in the antibiotic resistant strains because that can cause an increase in prevalence, which is just how often people are actually coming down with it. All right, and then lastly, some viral infections. So genital herpes, so HSV2 or HSV1. HSV1 more possible with oral sex. The lesions are going to be similar in HSV1, and so what happens is you get these blister-like vesicles that kind of develop all over the body in the genital region. You get recurrent outbreaks, and so you might get maybe like a tingling or an itching sensation, but these lesions are going to be extremely painful, and that's how you will know. So after this acute stage, the virus actually migrates back to the dorsal root ganglion where it stays in your body. It stays latent until some kind of a stressor activates it again. And so this is what that looks like right here. Obviously, female on this side and male on this side. And so reactivation, again, that's what I was just talking about, is what you have to worry about with genital herpes. So any kind of stress, illness, or menstruation, any of these things can cause you to have a flare up for herpes because, again, it sits in your nerves and it stays latent. You can use antiviral drugs for treatment and prevention, but if you are infected with genital herpes, this is technically really considered lifelong. And then condylomata acuminata, I don't even know how to say that. That sounds like Hakuna Matata to me, but it's so genital warts. So this is caused by HPV. So the incubation period can be for a long time, actually, so up to 6 months. So that means that you might not even know that you've been infected for 6 months, and it can be asymptomatic. So the warts will vary in appearance, but typically wherever the virus came in contact with the body, that's where you can expect these warts to be. You can remove these warts by a bunch of different methods. The real problem is that some of these can actually expose you to cervical or vulvar cancer. And then lastly, we have our protozoan infections. So trichomoniasis is the biggest example, comes from Trichomonas vaginalis. This is a protozoan parasite. The good thing is that it's a localized infection. So in men, it's pretty asymptomatic. In women, though, it can be kind of subclinical. So if the microbial balance in the vagina shifts one way or the other, you might start to see the symptoms, and it can cause intense itching. And so the treatment for both of these is treating it systemically. Yeah. All right. Thanks for listening. We got one more week. You guys got this.